Thank you for all of those who hopped onto this breakout this morning. You may have heard me say this already once, but I'm Reed Plimpton. I'm the project manager for the Northeast Telehealth Resource Center. I'm very happy to be joined and get to introduce Bonnie Britton, the co-founder and CEO of Reconnect for Health, but also a board advisor and consultant for our colleagues at the Mid-Atlantic Telehealth Resource Center. Bonnie is going to be taking over the talking in just about a second and talking about remote patient monitoring 101. And for those of you that haven't had a chance to look at the agenda, you can also catch Bonnie in about an hour talking about remote patient monitoring 202. Bonnie, take it away.
Okay. Good morning, everyone, and happy Friday. I'm very happy to be here and talk with you today about remote patient monitoring. And thank you for your time and attention today. And as Reed had said, if you have any questions, please post those questions and we will respond to those at the end of the session today. Okay, well, let's get started. So what are we going to do during this hour and 15 minutes? Really what I want the takeaways to be for you is to look at all of the different use cases for remote patient monitoring, and we're going to explore some of that. We're going to identify remote patient monitoring conceptual models. This is an area that I don't think a lot of people put enough emphasis and time on evaluating and determine what is the best conceptual model for your program. Then we're going to discuss the technologies that are out there and available, and then we're going to spend the closing time together to discussing the CMS, the 4 CPT codes for RPM reimbursement from CMS. Okay, so what is remote patient monitoring? This is a 101, so the perspective I'm coming from is that you don't know a lot about remote patient monitoring. So basically, remote patient monitoring has been around for 23 years. I started the first program in North Carolina and the 15th in the country in 1997. So it has been around for a long time, but it took COVID-19 to really push it to the forefront, and really excited to see all of the funding that has been out there for remote patient monitoring and the interest that has just exploded over the last several months. So basically, remote patient monitoring is patients collect their own data in their home, and that data is encrypted and transmitted for someone to review. The someone to review usually are nurses that review that data. And the biometric data can include a patient's weight, their blood pressure, their heart rate, their oxygen level, their glucose readings. It could include spirometry, it can include ECG, but any biometric data that the patient needs. I want to stress here that it's essential to customize the devices that you need for your patients based on their health condition. And what I mean by that is a lot of vendors will provide a kit that has, let's say, a scale, a blood pressure, heart rate meter, and a pulse oximeter, and that is given to all patients. Well, if I'm a patient and I don't have high blood pressure, I'm probably not going to take my blood pressure on a daily basis. So therefore, I become non-adherent. So it's super important to select the data devices that are specific to that patient's condition. Pre-COVID, patients had to have a chronic condition or conditions. During COVID, that has been lifted, and patients with acute chronic conditions can also receive remote patient monitoring under the CMS reimbursement codes, which we'll get into later. So let's talk about use cases. When I always say, if you've seen one remote patient monitoring program, you've really seen one remote patient monitoring program, because the diversity of where our patients live and the needs are dramatic. So hospitals and health systems, the primary reason hospitals and health systems have embraced remote patient monitoring is really to reduce less than 30-day hospital readmissions. And now they're focusing also on reducing less than 90-day hospital readmissions, reducing their ED usage, and it lowers total health care costs. So for a hospital and health system, I know we worked with one hospital health system that had one of the worst scores for less than 30-day hospital readmission rates in the country. and implemented a program with them 5 years ago, and they've been able to reverse that trend, and where we were able to collectively reduce less than 30-day hospitalizations by 68%. So all of this for hospitals and health systems is a cost avoidance model. The other entity are home health agencies, and that's where remote patient monitoring began in 1997. It began there to reduce the windshield time of nurses that are taking care of home health patients. So home health agency patients can utilize remote patient monitoring as long as there's a physician order. For the other locations, you do not have to have a physician order, but it is required for home health. And the reason for that is there was legislation passed in 2000 that stated that home health agencies can utilize remote patient monitoring as long as it does not reduce ordered skilled visits. Meaning that if a home health agency goes out on their start of care and they determine the patient needs, let's say 10 in-home skilled visits, and that's what they put on the plan of care, and the provider signs off on that, they can't then decrease those number of in-home skilled visits from 10 to 5 and supplement it with remote patient monitoring. What they can do is they can, during that start of care, create a visit pattern that's a combination of in-home skilled visits and remote monitoring on a daily basis. So the the average cost of an in-home visit within a home health agency is around $145 per in-home visit. So being able to reduce the number of in-home visits in your an established plan of care really is a benefit financially for home health agencies, because they're paid on a prospective payment system, meaning they receive a certain amount of money for a 60-day episode of care. So if they lower their total cost, then they have more profit at the end of that. Also, home health agencies are interested in reducing their less than 30-day hospital readmissions. And just this January, CMS is now allowing home health agencies to include the cost of remote patient monitoring in their annual cost report. That has never been allowed before. You can talk to one home health agency and they go, this is great because I'm not at my cap for my cost report. So therefore they can include all the expense in that cost report to increase their revenue. Other agencies you talk to, they're already at their cap, and it's not as much of a financial benefit. Nursing homes now are really looking at and using on the acute side of nursing home care to reduce less than 30-day hospital readmissions and also to reduce ambulance transfers. Primary care provider clinics, last year, January 1st, 2019, there were 3 CMS CPT codes that were approved for physicians to be able to bill. That really did not take off as much as the industry had hoped that it would, and the primary reason for that is they require direct supervision of the nurse monitoring the patient, meaning the nurse had to be under the same roof as the provider. Well, 99.9% of all remote patient monitoring programs are not set up that way. So existing health system programs that implemented RPM could not bill because the nurses were not located in that same building as the provider. So all of us collectively across the country reached out to CMS and helped educate them. And in January 1st of this year, now for those CPT codes, that can be done under general supervision, which means the nurse monitoring that patient can be anywhere. And we'll get into that more when we talk about the reimbursement, but there are 4 codes that we're going to discuss today for primary care providers to receive reimbursement from CMS. The other big financial use case for primary care providers are increase in MACRA and MIP scores. And those are patient satisfaction is different areas of quality improvement. And if you meet certain scores, an increased score, then there's an increased reimbursement. The other area that we've seen more and more in the last 2 years, 3 years, are health plans that are embracing remote patient monitoring to not only lower their expenditures, but to increase the quality of the patient's lives that the health plan is covering. And so the majority of all the large health plans now that in some form or fashion are offering remote patient monitoring services. Okay, patient populations. I always say the greatest barrier to remote patient monitoring is your lack of imagination. Typically, the patient populations that are primarily that are focused on are cardiovascular disease, including hypertensive, tension, heart failure, post-CABG surgery, patients who have had a heart attack, pulmonary disease, COPD, asthma, pneumonia, kidney disease, diabetes. However, having said that, one of the areas that we have been exploring more and are hopeful that others will follow suit are cancer patients, because cancer patients have a chronic condition, and cancer patients can benefit greatly either through a video-based remote patient monitoring platform for video visits, for support, education, counseling patients, as well as the biometric data because for patients who are going through chemotherapy. A lot of patients going through chemotherapy, they lose weight following their treatment, they don't rebound that weight, and it's time for another treatment. So we've seen a lot of success for patients with cancer diagnoses. Patient locations. Patients can be located anywhere. There are no geographic restrictions on remote patient monitoring, as there has been for telehealth pre-COVID. So the patients can be in their home, they can be in anyone's home, a nursing home, assisted living facility, group homes. We've even had patients who have lived in a motel, and we would call the front desk and they would connect us to the patient. We had one patient who actually lived in a school bus and had electricity running from the pole to the bus. So anywhere the patient is located, CMS recognizes that as an appropriate place for remote patient monitoring. Okay, let's talk a little bit about inclusion and exclusion criteria. So when I started in remote patient monitoring 23 years ago, it cost about $25,000 a home to implement remote patient monitoring. So you can well imagine everything was grant funded, and you were trying to be as cautious as you could to make sure you selected the most appropriate patients to receive these services. So historically, inclusion criteria has been very strict, meaning that it may say patients with heart failure who have had 2 or more hospitalizations in the last 6 months, multiple ED visits, etc. So it was super strict to really force organizations to focus on the sickest patients that are out there. That, however, has changed dramatically. I just had a video call with a vendor that the price points are so low now that their blood pressure sells for $80. That's $80. I mean, so it's super inexpensive now. With the CMS reimbursement rates, it's really caused vendors to lower their per patient per month fees to be underneath that amount of money that CMS will reimburse. So I really encourage folks that I'm talking with to have an opt-out approach, meaning that, okay, if you're a health system, a primary care provider practice, a home health agency, no matter what entity you are, remote patient monitoring should be an extension of your current services. So if your focus is COPD and heart failure, for an example, that every patient that has COPD or heart failure are eligible for this program unless they're excluded. So this approach makes it a lot easier to identify patients. It makes it a lot easier to scale your program, to maximize the cost avoidance and or the enhanced reimbursement, depending on the setting that you're in. And it also makes it a lot easier for patients to understand that, okay, the hospital's discharging me, but they still care enough about me that they want me to be included in this program so they can keep an eye on my health. So it's a more positive, inclusive approach. So if you take that sort of approach, then what would exclude the patient? The very first thing is unable to transmit data. And I can't talk about this enough. It's super important for you to understand in the area of the country that you're in how data can be transmitted. Is it that the patients have a phone line? That's the worst option, but sometimes people live in an area of the country like Eastern Mountains, Kentucky, where there's not cellular service, they don't have internet, and all they have is a telephone line. It may be that your cellular coverage in your area is best with Verizon. And if it is, then you don't want to lease or purchase devices that transmit only via AT&T. It's important to understand if patients have internet and Wi-Fi. So it really do some homework to understand in your communities and in the population of patients that you're going to serve, what is the best way to transmit data? And then you go and look for vendors who transmit data so that you can be successful. Another exclusion criteria is the patient's unable to learn how to use the devices and there's no one in the home to assist them. We have seen occasions where patients really wanted to do this but couldn't learn to get that blood pressure cuff on. So if they're a home health agency, when an aide comes in the home, they assist the patient. We've had other patients who the next door neighbor would come over and assist them. We've had patients who their children would come before work and assist them with using the devices. The only device that's difficult to use at all is the blood pressure cuff, and we'll talk a little bit more about that. The other thing is that the patient is unwilling or unable to communicate with the healthcare team. So a lot of patients we have found have Obama phones. So they have 20 minutes of data a month. And we found that a lot of those patients don't want to use their 20 minutes of time to communicate with the healthcare team. Or there will be other patients and they say, yeah, I want to participate, but then you call them, they don't answer the phone, or you call them, leave voicemails, and they don't return your call. So they've got to be willing and able to communicate with the healthcare team. And then lastly is an unsafe environment. And what do I mean by that? It could be that the house is infested with cockroaches, and cockroaches love warm technology. It could be that the person has a hole in the ceiling and there's potential water damage. It could be that the patient doesn't have anywhere in the home with a flat surface to place a scale that is not on carpet. So those are the type things that you look for excluding a person. A lot of times you won't know that until you go out into the patient's home, whoever does that install. to make sure, but you can assess their transmission ability as well as their cognitive and physical ability to be able to use the devices and their willingness to communicate. Okay, let's talk about remote patient monitoring conceptual models. Prior to January 1st of this year, it was very difficult to where you could not bill for outsourcing remote patient monitoring services. So when you go on this journey of remote patient monitoring, you need to think about the very first thing is equipment. When you purchase or lease your devices, do you have the resources and space to receive the inventory, to store the devices, and then do you have someone that can pull those devices, place them in a bag or container ready to go into the patient's home? And then are you going to send someone to do the installs and deinstalls, or are you going to have the device vendor do those things for you? So here's an example. So I was working with a home health agency doing some consulting the other day, and they they did not want to manage any equipment at all. They didn't have the space for it. Health plans don't have the space for it. They don't like, to do these installations. So a lot of them will outsource that to the vendor. So the device vendor then would receive a referral in their software. They would pull, test, and ship the devices to the patient's home. The patient would have a phone number to call, an 800 number to call once the devices have arrived. And then that device vendor would provide instruction and remote support, as well as have the patient collect their readings and verify that the data transmitted. Or you could have, as I said, someone in your organization that's responsible for doing that. Now, for equipment installation and deinstallation, the gold standard is in-home patient installation. That doesn't mean that outsourcing it is not a good thing. It totally depends upon your organization, the amount of resources you have. If you want to have, if you don't want to have to hire someone and pay benefits and all of the things that go into paying for a full-time FTE, then outsourcing that process may be better. And I'm going to give you guys some examples here in a minute. So starting January 1st of this year, remote patient monitoring can be outsourced. So for an example, we were working with a large health system in Maryland, and they determined that they wanted their community health workers to manage the equipment and do the installations and the deinstallations, but they didn't want to hire an FTE to do the monitoring. So they outsourced that monitoring to a third party. So think about, as you're going through your process, do you have the staff to do these things, manage equipment, actually doing the monitoring of those patients? And if you don't, what are look at options for outsourcing those services? Here's an example. So one health system that I was telling you about in Maryland, they insource and manage their device management installations, and they outsource their remote patient monitoring. And you think, well, how does that outsourced remote patient monitoring work? It works based on the workflow that the organization set up. What they wanted in this example is they wanted, anytime a patient's data is outside of a set alert parameter, the nurse calls the patient, they validate that it's their data, they conduct an assessment, and if needed, based on the assessment, the nurse believes the patient may need a medical intervention. In this example, they escalate that to the outpatient case managers. In another organization, it may be that you escalate that information up to the patient's primary care provider or their specialist or whomever they want to receive that data so that a medical intervention can occur. Example number 2 is where organizations do all of the device management installation themselves, and they provide the remote patient monitoring clinical services themselves. Both examples are perfectly appropriate. It again depends upon your organization and your resources. In health plans, the large majority of all health plans outsource device management installation as well as remote patient monitoring clinical services. And the reason for that is health plans don't have staff to go out into the home, and a lot of health plans can't provide the actual clinical services themselves. Okay, so when looking at technology, the one thing I want to say is all of the device vendors that have devices for sale or for lease are FDA approved, number one. So I look at the actual peripheral not as important as the software platform, but we'll go through, and this is an example of a scale. Anytime I'm looking at a scale, making recommendations, the broader the base of the scale, the better. Because the majority of these patients are older, some are obese, some have trembling and difficulty standing still. So the wider the base of the scale, the better. The other thing I like to see in a scale is that the patient doesn't have to do anything except for stand on it. There's no buttons to press. In the past, there have been, and patients are trying to tap it with their toe. You want something where the patient just simply stands on that scale, and then a reading comes out. A large majority of them will verbally say 128.4. Others will have a blue light that flashes up so that the patient knows that reading has been taken. So patients get up in the morning, they empty their bladder, they stand on the scale, and then they're done with their weight for the day. Majority, everybody has blood pressure and heart rate meters. This is just one example. The way that we train patients is, I should have put these slides in this order, is patient gets up in the morning, they empty their bladder, they weigh. They go to the kitchen. If they're diabetic, they check their glucose reading. They take their medications, they have their meal. They weigh, if they have high blood pressure, they wait at least 1 hour after taking their medications. They go and they sit in their easy chair. They place the cuff on their arm. They press a button and the cuff inflates, and then they receive a reading. We always instruct them to take 2 back-to-back blood pressure readings. And the reason for that is the majority of the time, the second reading will be more accurate than the first reading. In training your patients on, the majority of patients have not put on blood pressure cuffs. So when blood pressure cuffs were designed, they were designed for applying it on the arm for someone else to do that. So all of you, I'm sure, put on a blood pressure cuff. So when a patient puts the cuff on, they have to pull the cuff in an awkward kind of situation. So what we do is during the install is to get that cuff, show them to get it above the elbow. The cord comes down, wraps around their thumb so they know they have the position correctly, and get the right fit for that patient, and then instruct them after just to barely release that Velcro, slide their arm out. Then the next time they take a reading, they simply slide their arm in. All they have to do is tighten it back a little bit, and that really seems to help patients feel more comfortable in taking their blood pressure by themselves. This is an example of a glucometer. This actually is, and I'm vendor agnostic, don't manufacture any devices and never recommend and say, you need to go with this company or that company. But this meter right here has a built-in cellular chip. So you don't have to have a transmitting hub or have a tablet to be able to transmit the data. And I've seen a lot more companies moving to this cellular chip. But thinking about what I said earlier, if this cellular chip embedded on here, it's T-Mobile. If T-Mobile doesn't work in your area, is this the best glucometer for you? Probably not, because you're going to have issues with transmitting data. The other issue with glucometers are you have to purchase strips for the glucometers. So what I've found, and they're expensive because a person may need to be taking readings 4 times a day, and you go through at least 100 strips easily in a month. So that can add up. What some organizations have done is the patient just uses their own glucometer and then self-reports. Self-reporting is never best practice. Self-reporting can't be used for reimbursement, but wanted to share that anyway. And then a pulse oximeter. And the patient simply just opens it, puts their finger in there, and then you get the oxygen level, and you do get a heart rate level. We don't recommend using this heart rate. It's not as accurate as the heart rate you will receive using the blood pressure meter. So I would always recommend using the heart rate alert from the blood pressure meter, not from the pulse oximeter. Okay. Next, let's talk about biometric alert monitoring and validation. And I'll start off with what I thought was funny. I was on a phone call with a gentleman, and he was trying to figure out this reimbursement rate for remote patient monitoring. And once you do 20 minutes of monitoring, you don't have to monitor the patients anymore. Well, that's absolutely not correct. Normally, patients are monitored Monday through Friday at a set time. 24/7 monitoring of remote patient monitoring patients. I've only, in my 23 years, had an organization ask for that once. I convinced them to let's not do it 24/7 because it's very expensive. And guess what? The patients have already done their readings. When they get up in the morning, 98% of all readings and alerts occur before 1 o'clock in the afternoon. So doing it Monday through Friday, we encourage the patients to take their readings 7 days a week, but the advantage of not monitoring them on the weekends is the patient has to learn how to respond when there's an abnormality. So, and I'll talk about that a little bit more in the future. So you monitor the biometric data Monday through Friday. Best practices is respond to that alert within 4 hours. And what I mean by respond is not just noting that there's an alert. It's actually noting that alert, calling that patient, validating the accuracy of the alert, validating that it is indeed their readings. Because sometimes a child or a cousin or someone will step on a scale. When we call to validate the accuracy of the alert, if it is theirs, we ask them if it's a increased weight. Did you empty your bladder before you weighed? Were you wearing the same clothes as you were yesterday? If it was a blood pressure, did you take your medication? Did you wait an hour? Did you rest in your easy chair for 10 minutes? So we go through and validate the accuracy of that alert. If the patient did not accurately take their reading, then you need to re-instruct them on how to do that, and then encourage them to then take another reading. Then, when the alerts are valid, a registered nurse will conduct a nurse assessment just like they would at a bedside, except for they don't have a stethoscope. They would provide patient education on all of these things. We really like to target education based on what the patient has communicated. For an example, if education worked with patients, we wouldn't be in the situation we're in today. So I'm going to use my mom as an example. She passed away 5 years ago at 93 years old, and she had heart failure. And if I had told her once, I told her 1,000 times, Mom, I know you love Chinese, but you can't eat Chinese because it's going to make you gain weight and you could go into heart failure. Did her behavior change? No, it didn't. Until we put remote patient monitoring in her home, and the nurse called her and said, Miss Perry, your weight's up today. Have you taken your medications? Yes, I did. Did the whole assessment, abdominal swelling, feet are swollen, etc. And she said, what did you do yesterday? What did you eat yesterday? And she said, my husband took me for Chinese. So that was an aha, and the nurse said, well, Miss Perry, if you don't want to feel this way again, we need to talk about you not eating Chinese food anymore. We could call that see, feel, change methodology. Patients see their readings. We help them articulate how they feel. I mean, when I say we, nurses, help them articulate how they feel. Then we help them make an association between what they did and did not do yesterday. And that's really where you see long-term behavior change. So as you're conducting that assessment and you're listening for clues, then you're going to provide the appropriate education based on what that patient's sharing with you. And then based on that assessment, if the nurse believes that the patient may need a medical intervention, we as nurses can't say, go take an extra Lasix. What you do is then you escalate that useful, validated, actionable data to the patient's primary care provider or to whoever the organization wants that escalated to get to a provider so that the provider can make a medical intervention, whether that is to call the patient and adjust their medications, whether that's to have the patient come into the clinic, which is probably not the case during COVID-19. But then the nurse documents those encounters. So the large majority, when you think about monitoring patients and the interventions that you have and looking at data, you're really looking at data over time and trending data. So one of the things that I always encourage people to do is, on a every other week or monthly basis, run trended data reports, graphs that can be sent to the primary care provider before the patient's next visit. And that way the provider can see over time, okay, the blood pressure, I changed medications on this day, blood pressure is still elevated, I changed meds on this day, it's still elevated. Or it may be, okay, third time was a charm, and now that blood pressure is coming down. I'm really going through this fast. I'm hoping you guys have a lot of questions. So I didn't think I'd live long enough to see CMS reimbursing for remote patient monitoring, so I was delighted beyond words to see these 3 codes in 2019, now 4 codes in 2020. And we want to start with who can bill these CPT codes. Pre-COVID, the primary medical provider of the patient. And you ask, well, is that the primary care provider, or is it the cardiologist, or is it the endocrinologist? The answer to the question is, who is primarily managing the patient's chronic disease? If someone has COPD and their pulmonologist is the one that is primarily managing the COPD, then the pulmonologist can bill. If it is a patient that has multiple conditions, but they don't require a specialist at this time, it would be their primary care provider. And that can be a mid-level provider or an MD that can bill for those services. Since COVID, in March, they now are allowing home health and hospice providers to bill for these CPT codes. That's a big deal. Home health and hospice providers have never been allowed to bill in the past. And so a lot of home health and hospice providers now are doing that. And I heard yesterday from a colleague, I don't have this confirmed, but I heard from a very large home health agency that CMS is going to allow this to continue. So again, I heard that. I'm not saying that's an actual fact. That needs to be validated, but we're all very hopeful that some of the things that have been loosened around remote patient monitoring as well as telehealth will not go back the way they were before. In addition, during COVID-19, rural health clinics and federally qualified health center providers can bill. What's interesting about this is rural health clinics and FQHC providers could bill in 2019, but they couldn't bill in 2020. But now with COVID, they can. So will they be able to after COVID? Hopefully, we don't know. Co-payment for these services, pre-COVID, there was a 20% copay where all organizations, primary care practices and other practices collected this on a regular basis. Some did or do, some don't. But on March 25th, 2020, that copayment has been lifted. And hopefully it will stay that way. We don't need any more barriers to care than we already have. Okay, so the CPT codes. The first one is 99453. And this is for the initial setup of the equipment, meaning that the patient is educated on the equipment use. Now, as we've previously discussed, best practice is in-home installation and demonstrating how to use the technology, having the patient return demonstrate to collect data, and the patient sign the patient competency validation form. That's best practice. But let's say you are a hospital and you're implementing a post-discharge program. You can actually provide the technology to the patient and educate them on that while they're in the hospital. Or they could come to the clinic and pick up the equipment, be trained there for that initial setup. Or the devices can be shipped to the patient's home for the initial setup. However you give the technology to the patient and the patient is educated, once that patient transmits 16 days of data, then the primary provider for that patient can drop a bill for an average reimbursement of $21 per patient. This is a one-time fee or reimbursement. Is this enough money? No, it's not. It's not going to cover the cost of going out in the home. It's barely going to cover the cost of shipping the devices to the patient's home, but it is a start. And so 99453 is the initial setup, patient education, and once the patient has transmitted 16 days of data, then the provider can drop a bill for 99453 with an average reimbursement of $21. Now, if you are monitoring and providing an initial setup for a patient with COVID-19, CMS says you only have to have 2 days of monitoring transmitted a month in order to receive reimbursement. But that's just for COVID-19 patients. Okay, CPT code 99454. This is the actual device supply, and the patient has to transmit 16 days of data in order to bill 99454. And so let's say you install the patient on 15th of the month, and from the 15th of July to August the 14th, that patient has to transmit 16 days of data. Once they have done that, then the provider can bill the average reimbursement nationally is $69 per patient per month. So what's important about this number? What's important about this number is any vendor, excuse me, let me take a sip of water. any vendor that's leasing you product that you're looking at, you need to make sure that their per patient per month rate is less than $69, because you want to have a little profit margin. What you don't want to have is them charging more than this to be able to have a good return on investment, financial return on investment model. So this is really is the driver of leasing amounts for remote patient monitoring vendors. Oh, I'm so sorry. Okay. And I know people are going to have questions. So then there's CPT code 99457. And this is the treatment management services. This is once the nurse reaches 20 minutes of time reviewing the data, calling the patient, doing the assessment, providing education, contacting the provider, and documenting what you have done. Once 20 minutes of time has been accumulated, the provider can bill, the national average is $54 per patient per month. This can be done under general supervision, so it can be outsourced. So what we're seeing a lot of primary care provider practices doing is they are trying to partner with vendors that their lease amounts are less than $69 per patient per month, and an outsourcing company that can provide can provide monitoring for the patient for the entire month. Once you reach 20 minutes, you still have to keep monitoring that patient. It's just you can drop a bill once 20 minutes of time has occurred. So those are 3 CPT codes that came into effect in 2019. And this year they added CPT code 99458. And that's 20 additional minutes of the nurse's time. So if I reach 20 minutes of time with the patient, the provider can bill $54 that month. If I reach 40 minutes, they can then bill the additional 20 minutes under 99458. A lot of people go, wow, I can do 60 or more minutes with a patient in a month. That's very difficult. Getting 20 minutes is easy. 40 minutes if your patient is really chronically ill, has just been discharged from the hospital. But the majority of patients who are, still working or still very active and their primary care providers are monitoring them, it's going to be difficult getting up to 40 minutes. But the potential's there. I do want to direct each of you to the physician fee schedule lookup tool. If you Google physician fee schedule lookup tool, what you can do on that, when you go into that screen, is go by locality and look at your location. I'm in North Carolina. I would pull up North Carolina. And then if you enter each one of the CPT codes, it will tell you what your reimbursement rate is for your state. Because what I've shared with you are the national averages. And states, it could be higher than that. It can be lower than that. Okay, I'm going to open it up to questions, and hopefully everybody's got a bunch of questions, because I went through that pretty quickly.
I'm pulling up the questions right now, Bonnie. I thought you did great. We do have quite a few questions here, but I think we also have a small enough crew that we'll give them an opportunity to kind of unmute and ask their questions live if they'd like to after we get through the list we have here.
Sure.
So here we go. We should all be able to see this right now. We will start with the top because it's been upvoted, which means more than one person was curious. Are you aware of any use of remote patient monitoring for patients in OUD or SUD treatment?
What is OUD and SUD?
Yeah, okay, so substance use disorder and opiate use disorder?
Primarily, historically, that has been used with video. okay? But there are opiate, and I wish my colleague was in here. We last summer had a physician out in California, and he was treating patients with opioid, trying to get them off opiates. And so they were utilizing it to check their blood pressure and something else I can't remember. And maybe I can get her after we get through that question to get her to come in and respond to that. But normally and historically, that has all been through video.
Sure. Yeah. Okay. And I think for folks so it sounds like maybe if you're interested in that question, that you might be able to learn a little bit more in the 202 session or follow up with Bonnie after.
Yep, absolutely.
Sure. So we'll move to the next one then. Did you explore, or were you able to stand this up to have patients do their own assessments for like sort of tech location, I'm assuming this is talking about, during the stay-at-home period? So go for it.
Yeah, so did you explore, were you able to have patients do their own assessments? So one of the things that for COVID and everybody staying home, there was one company we worked with who had IVR technology, interactive voice response, as well as pulse oximeters and thermometers. And so those were able to be shipped to the patient. The thermometers were not integrated like with Bluetooth. So what would occur is at a certain time each day, or 3 times a week, 4 times a week, however often you wanted that, then it would call the patient automatically and ask them a series of questions. Do you have a fever over X? Are you experiencing shortness of breath? All the different COVID questions that you were asked, and then the patients you have that data, and then they could report also on their oxygen level. So absolutely, I think in the future, we were on a call yesterday where people are going to want to have pulse oximeters and thermometers in their home in the future. And by having that in a low cost way to be able to have that access to care, absolutely. But you do have to ship it from home from somewhere else to the patient.
Can I tack a follow-up on there? Because I think that's a great answer, but it's not what I actually had interpreted it as. I was thinking that this might have been asked around the time that you were talking about how important it is to think about where the scale is going to be sitting in the house, or some of the technology placement, and how you typically have staff that go and help the patient explore this the first time you're setting up the interactions.
Okay. So if you don't go in the home and do that, then the device vendor, when the patient calls them to set up their equipment, the device vendor will say, I need you to place the scale in your bathroom if you have room. If not, it needs to be on a hard, flat surface. It can't be on carpet. If they would instruct, now I want you to take your blood pressure meter and your pulse oximeter, and I want you to put that beside your easy chair or wherever it is that you rest. Glucometers, we usually instruct the patient to have that in the kitchen or wherever they want, but usually they do that in the kitchen. They check their blood sugar and then they eat. Did that answer it?
No, that 100%. And I think it's great because that's kind of what I was teasing out, is I was figured that you had questions when you talk to the patient, or the vendor does, that can help them place it if you were not able to do so. But we do get a couple more in here, and I do want to make sure you get the chance to touch on as many of them as we can. So the next one is, do you have any patient satisfaction metrics from the technology that you have tried in your various interactions?
Absolutely. So, gosh, I don't know, 10, 12 years ago, I was the chair of the American Telemedicine Association Special Interest Group for Remote Patient Monitoring. We actually developed patient satisfaction metrics that probably are still available through the ATA. But just so you know where to go to look to develop patient satisfaction surveys. And do we have patient satisfaction metrics? Absolutely. And the things that patients love remote patient monitoring. They love it because they know somebody's watching them. They know that if they're going, somebody's going to identify something before they get in trouble. And I'm not sure what just happened to the screen. So, Reed, are you there? Hello?
It looks like Reed has gotten knocked off somehow. Let me go back and share the rest of the questions here.
Okay, that'd be great.
You should be able to see some of these questions.
Okay, the patient satisfaction. What really the metrics you want to look at are ease of use, and then around the services that are provided, that you feel more engaged in your care, you understand how to respond when you have an event, etc. Let's see, has your company explored any tech that allows for storage of readings, or do you focus on techs that utilize immediate transfer of data? Almost all remote patient monitoring is immediate transfer.
Bonnie, I am so sorry. My computer just turned off. I think it's a little humid in my office today. Are you reading your own questions and answering, or you want me to hop back in?
Yeah, you can either way. I was reading them. We're on best advice if have AI provided by a company, but the company is relying on facility for all else. Education devices, etc. Your point about carrier chip is great advice. Thank you. Okay. I'm not sure I understand the question. If whoever asked that would like to be able to chime in.
And yep, I'm working on it, Carol. So we're going to unmute you, and you should be able to go ahead and speak.
Thanks very much. Hi, Carol from UCSF Medical Center in California. We have a company that has the great AI, but they're kind of looking to us to make the decisions about the devices and, you know, assess our own ROI, do the shipping, do the training, pick the devices and stuff like that. I guess just following what you said during this presentation would be your best advice, but do you have any other kind of, you know, I guess it's like we're like our own startup.
Yeah, so, you know, a lot of organizations have integrated artificial intelligence into their software platforms.
Yes.
But so it sounds like to me, and I may be wrong, but they have a software platform for AI, but then if you go and get the devices from a third party, how's that data going to get into their software to utilize their artificial intelligence?
Correct.
I'm not quite sure
how
that would work. If you're interested in a vendor who has artificial intelligence embedded in their software and have devices, then you know, I could help you and make some contacts so that you could explore that. But that seems disjointed to me.
It seems like it to me too. Thank you very much. I appreciate it.
Are you aware of some equipment that allows for BYOD? If I had a glucometer with a USB plug that would integrate into your device. Yes, there are companies that do have BYOD. That is becoming kind of a trend in RPM, where the patient has an app on their phone, and then that they go and purchase themselves Bluetooth peripherals that can be captured in the app by the device vendor. And if you want specific companies that do that, you're welcome to contact me. I'm vendor agnostic, but I will be more than happy to share the companies that I know have that technology, and then you could go out on your own and, vet those vendors. What video conference platform do I use for any face-to-face consults? Actually, we utilize a platform called Adaptive Telehealth. Behavioral Health Innovations, and we did a lot of vetting 3-4 summers ago of every video platform that's out there, including Zoom. And what we found is that a lot of them do not meet HIPAA requirements. When you really drill down into those HIPAA requirements, we found Adaptive Telehealth platform. What they did is they have a license from Zoom, and then they took that Zoom platform and put it behind 3 levels of security. So it is a Zoom platform, but it is behind 3 levels of security. And it's super easy because the patient doesn't have to, Zoom's super easy. All you have to do is click a button and you're on. But you really want to be careful. Right now, CMS is letting you do it on Skype in any way you want to, but that's going to go away. The HIPAA security is definitely going to come back. And my fear is, or not fear, my concern is that people are out there and they're rapidly implementing these programs, very loosey-goosey, and that once things get tightened back up again, those organizations are going to have to pivot and re-look at how they've set these programs up. All right, what other options for blood glucose monitor, since you will need to monitor and test strips? What are the other options? So a lot of the brands of glucometers that are out there on the market for patients to purchase, a lot of these device vendors have created a dongle or a connector that you plug into the glucometer, and it would transmit the data electronically. Again, what other options? Yeah, the patients like to use their own device. So if, like some primary care or federally qualified health centers, I worked for one for 6 years, and we provided glucometers free for the patients. And so for our patient population, and we implemented remote patient monitoring, we wanted to find a company that could create a connector for those glucometers that we give patients for free, and so that it would electronically transmit, because it has to electronically transmit to be able to have reimbursement. If you're not interested in reimbursement, then the patient could use their own meter and strips and self-report.
And Bonnie, I would think we have one more question that, to the point in the chat, I think I was starting to read for you before I lost my connection. So just to kind of wrap it up, can you please clarify, if a home health nurse practitioner or physician is managing a patient's care and ordering RPM services, that providers can bill for CMS under Part B versus Part A, as home health services are usually billed?
That's correct.
Okay, I was saying there's a secondary question there, but I'll wait.
That was listed in March.
Okay, and so then this follow-up to that was, if the patient also has a PCP/specialist involved in care, but they did not order the RPM, what is their involvement?
Okay, so this is where it comes back to the question of who is primarily in charge of that patient's treatment plan. So I had a conversation with a home health agency last week, and they had 2 different models. One model was they received referrals from physicians, and that the physicians were the primary manager of that patient's care. So it would be that PCP that could bill. versus they had a subpopulation of their home health agency where they had their own hired nurse practitioners in that home health agency, and that subpopulation of patients was managed by the home health agency's mid-level provider. Therefore, that provider can bill the service. Both can't. Only one can. So it comes down to that question of who is primarily in charge of managing the care of that patient.
Gotcha. Mel, did that answer your question? Not to put you on the spot, but.
Yes, thank you very much.
No problem. Thanks for asking it. And Bonnie, thank you for a wonderful first of your 2 presentations. I will just direct people here really quickly to the evaluation, which is for Bonnie's session specifically. You can fill out the overall event, but you could also wait another week and we would understand why. For Bonnie's session, this would be right where you found the question tab underneath her Zoom link where you joined us today. The slide should be there as well. And with that, please join me in thanking Bonnie again. Thank you all for joining us. Feel free to get a stretch break or to get some more coffee or whatever you're doing before our next breakout session, because it is not too far away.
Thank you, everybody.